Sorry uh, for this delay, and thank you for cooperating and waiting for me. And I'm Chief of Pain Medicine and Palliative Care at Artemis Hospital. And I'll take you through the journey of what is the latest in chronic pain management in present day practice. And I'm sure at the end of the meeting, you will be quite aware about what chronic pain is all about. And we will talking about both cancer and non-cancer pain management in today's scenario. And अरे चल क्यों नहीं रही यार अरे यार I think this is hang up. Yeah. So this is my team. And when nothing is possible without team, we have Dr. Meenu, who is a cancer pain and palliative care expert, and then full-time pain and palliative care nurse with us. So uh, this is what we'll talk about, the evidence-based approach. Chronic pain is a very difficult subject to treat, and we need to have some evidences and target-based approach rather than just giving painkillers and uh, try to treat the patient. So, first of all, our job will be to understand where is the pain generator and how we can treat this pain and treat that pain generator. So, as you know, chronic pain is anything which is more than 3 months and beyond the time for healing, and it affects your sleep, your work, relationship, everything. And as you know, it's very common in the society. So let's first start with the facial pain and headaches. Today I'll be focusing myself on the intervention part of the pain management, because that we are looking at. But if I see the procedure that we do is almost around 12 to 15% of our total OPD, and we are able to manage 85 to 87% patient with medical management and rehabilitation. But today we'll be talking about intervention, so I'll be skipping about that theory part. So what are the drugs and all this? uh, so in facial pain, let's first thing that we start with is trigeminal neuralgia. As you know, it's a very difficult disease, and it is pain, sharp shooting pain in one of the divisions of trigeminal nerve, maybe V1, V2, and V3. And 80% of the patients can be managed with the medical management. And to diagnose a trigeminal pain, the character is very important because diagnosis is primarily based on history. So it's a sharp shooting, stabbing, electric shock like pain, and which is very severe. So patient can't eat, patient can't speak, patient can't wash their face, they can't lie under the fan, so something like that. And they have current like sharp shooting pain, and people are not able to eat. And this is classical trigeminal neuralgia that we treat. And usually in trigeminal neuralgia there is no neurological deficit. As you know, the prime medical management is through carbamazepine and oxcarbazepine or eslicarbazine. And we are talking about this radiofrequency ablation, though microvascular decompression and gamma knife. Gamma knife particularly, it's expensive, and its effect come in 2 to 3 months, and success rate is around 85%. MVD is definitely a surgical procedure, but we'll talk about radiofrequency ablation. It's a daycare procedure, almost take half an hour to do, and the result are more than 95%. And if you see, I've introduced an electrode into the trigeminal fossa. You can see it on the clavus on the left hand view, and these are the oblique. You can see upper view. You have mandibular foramen, and then lower view, AP view. So this way we treat the trigeminal pain, and we do stimulation and ask the patient where the patient feels the pain, and patient feels the pain in the same areas where patient feels the pain. And once we confirm that the position of the electrode is perfect and patient feels the pain in the same areas, we go and do radiofrequency ablation. And I am putting it on record that presence of vascular loop is no contraindication for doing RFA. Um, though the conventional teaching is that if there is a vascular loop, you should do MVD. That is not the case. You can do RFA, and we have treated so many patients with vascular loop. This is gentleman who had pain for trigeminal neuralgia for 17 years, who attempted suicide twice, survived, and we treat him. And he is explaining that after this, he has complete pain relief, though it is in Hindi. So I'm not going into the detail of that talk. So, but you can see the patient was having pain in V1, V2 area, and we treated him. Similarly, you can do the nerve blocks, supraorbital, infraorbital nerve block if it wants. But the perfect result comes from trigeminal ganglion ablation only. So it is primarily idiopathic trigeminal neuralgia, and then glossopharyngeal neuralgia. Patient feel pain in the throat on deglutition, on eating, and all these, and very disabling. Patient can't eat, they can't swallow, and you can do PRF of the glossopharyngeal nerve under ultrasonography or this under fluoroscope. And for ENT point of view, Eagle syndrome and pain coming from cancer of the tongue, pharynx, and tonsillar bed, you can do this PRF. The average duration of pain relief with PRF is around 9 months to 12 months, and it works wonderfully well. So this is how we do. And then sphenopalatine, it's a ganglion which is sitting deep in the base of the brain, in the pterygopalatine fossa, and it is particularly useful for cluster headache which are not responding to medical management, migraine, and atypical facial pain, particularly Burnington syndrome, where patient feels kind of burning and sensations and all those sensation on the tongue and mouth. So this is the answer, and this is we are doing sphenopalatine ganglion RFA. You can see the needle being placed in the pterygopalatine ganglion on the lateral view. You can see the inverted vas where the needle is being placed, and this is how we do. This is AP view, and this is how. Now, this was a patient which came to us from Oman, and this patient has bilateral burning tongue, severe bilateral burning tongue for many years. And we treated him single sitting. You can see needle on both sides of the face. And if you see the cath lab setting, and now it was done in pre-COVID, and patient is absolutely well. So you can see the both sides. The electrode has been placed into the pterygopalatine fossa. Sphenopalatine ganglion ablation is going on. So this kind of atypical facial pain. It was young patient for Oman. He was just around 27 years old with very disabling, distressing pain. And in one sitting, the pain was treated, and this procedure took us around 1 hour to do from both sides. So this is how it works. And then coming to the neck pain, this is one of the leading cause of disability, in particular the patients, particularly when they have a lot of mobile use and uh, they have headache. And you know what is a surprising fact? 70% of the migraine which are being treated, they originate from the C2, C3 nerve. This is called cervicogenic headache and occipital neuralgia. And they are cervicogenic headaches, and they can be treated in single sitting. I treated a female who had this cervicogenic headache for last 27 years, and with single sitting, we ablate. I'll show you the third occipital nerve, and you can have wonderful results. So this is, you can see cervical facet which are shown in red, and cervical facet can cause suboccipital headache, cervicogenic headache, neck pain, shoulder pain, scapular pain on the back of the scapula. So if you go through this chart, this is the referred pattern of the C2, C3, C4, C5, and C6, C7 in yellow color. You can see the pain from the C6, C7 facet is referred to back of the scapular mid thoracic area. And very difficult to diagnose. We forget about these kind of referral pattern. And in a single sitting, you can treat C2 to C6, do median branch RFA, and you can treat cervicogenic headache, you can treat neck pain, you can do shoulder pain and the scapular pain, everything you can treat in a single sitting. So you can see these kind of spine, nobody is going to operate on them, and they have severe pain, and they can be, this is block, diagnostic block first to see whether patient will be benefited, and this is RFA. Again, we are mimicking the same pain. If we stimulate C2, the pain will go to the occipital area. This is what we are trying to do in this patient, and patient feels pain going radiating back to her occipital area after stimulating C2, C3. This is what we are doing, and this is again we are stimulating the patient, and procedure is a daycare procedure done in cath lab, and 90% and more cervicogenic headache and neck pain, shoulder pain, these kind of the pain can be treated. This is our radio frequency generator from Hillard, the one of the best in the world right now. So this is how in cath lab we are doing, and patient has wonderful results. Now, this is very interesting patient. You just listen to her. She came to her from your countries only, and listen to her. She was diagnosed as fibromyalgia, and how we treated her. Please listen to her.
Hi, my name is Jamila Isma. I was referred to Artemis Hospital after going through a lifetime of unexplainable pain that there were no possible solutions in my country for. When I reached to Artemis, Dr. Ashu on pain management asked me to do a few scans and found a solution for me. I was suffering from severe back pain and neck pain. He did a laser procedure on me.
She's saying radiofrequency ablation as RF, a laser procedure,
which helped the inflammation to go down. And this provided me with a lot of reliefs with the help of a few medications and exercises. After 1 month, I feel like a brand new person with 70% less pain. And I'm very grateful to the whole Artemis team.
So what are the important points? She sent this video herself from her swimming pool after 1 month. I didn't ask her. She was so happy. Now she was going through unexplainable, untreatable pain as fibromyalgia. Her life was hell. So we identified the pain generator and did 2 radiofrequency ablation, one for the neck and another for the lower back. And uh, we gave her exercises, gave her videos for exercises, did help her to undergo rehabilitation, and after 1 month she is a brand new person. So I see lot of young patients where their pain are not being treated. I don't know why people not are able to understand from where pain is coming, and then you can really change the life. God is great. With his blessing, the patient is very happy. So we have a lot of such kind of patients. Similarly, you have cervical epidural block, cervical PIVD causing radiculopathy, and cervical disc which is causing radiculopathy in the upper limb. If you don't have myelopathy in present day practice, you don't have muscle weakness and very severe sensory deficit or pain, you can treat the radicular pain with cervical epidural injection. You don't need to operate the patient, and these are myelopathy, and these weakness patient are just 3%. So 97-95% of the patient you are able to treat. This was again a patient, international patient, and you can see she was 135 kg, and you can see the needle, the epidural needle, it was all inside the spine, and these are the images you can see of the patient, and patient was very happy, and without any surgery. So you see the epidural needle is coming, it is going inside the spine on the left side. Now you can see the nerve and dye going up and the nerve opening up, and then we inject dexamethasone with normal saline, and most of the patient they are benefited. And since we do in cath lab, so this is very important to understand. It increase the safety of the patient. This patient, if you can see on the right side, there is a black streak. It was dye in the epidural space, but I could see that something is abnormal. I did DSA on the cath lab on the table, and if you see, you can see the epidural veins. You can see lot of epidural veins. The dye is also going into the epidural space and into the epidural vein, and see, you can see the web of epidural vein. So doing the procedure in cath lab increases the chances of success rate and decreases the complication. This is how you can see the um, web there. So if you do the patient in cath lab, you can really save the patient from undue complication. If I would have injected the medicine in this patient would have died on table. So it is important to you do in your patient in advanced cath lab with advanced machines, which is important for the safety of the patient. Now coming to the thorax. So there is a lot of patients for thoracic festogenic pain as shown in the red. And this kind of pain, I'm really surprised. People are not diagnosed. They are suffering. Their pain is coming from traveling from back of the chest to the front of the chest. They can't sleep in night. They wake up in severe pain. I put up this video through Artemis 2 3 years back, and there was more than 3 million hit for this mid back pain. So we get a lot of patients of mid back pain which are being untreated for years, and we do radiofrequency ablation of thoracic facets. You can see the radiofrequency ablation of thoracic facet, and it gives wonderfully good results. This is what we are doing, the thoracic facet RFA, and this is one of the very rewarding procedure with mid back pain, festogenic pain in the back of the chest, and it gives wonderful results. Similarly, T2 T3 sympathectomy for complex regional pain of the upper limb because of brachial plexus injury or some after the surgery, like breast cancer surgery, post amputation pain, peripheral vascular disease like renal disease, and many kind of neuropathic pain that is not responding to conventional treatment. You can do sympathectomy of upper limb, that is T2 T3 sympathectomy. This is the case where we did for vascular reason. You can see the black hand, and after doing embolectomy, patient he was not recovering. We were called in the middle of the night to do sympathectomy, and I'm very proud to say that I am one of the our institution is one of the few institution which is only doing percutaneous sympathectomy. Otherwise, many doctors around the world in India are still doing it by thoracoscope. But you can see we are placing two electrode at T2 T3. These are the oblique lateral view and oblique view, and this is AP view, and you can see the two electrode placed and patient feeling the pain going down to the arm. So this way upper T2 T3 sympathectomy for upper limb can be done in cath lab rather than doing surgery and doing sympathectomy. I'm very proud to say that our institution does it on daycare basis in cath lab without any open surgery. I think nobody around in Delhi NCR is doing this kind of procedure, and patient is feeling pain going to the arm. So this is how we do it. And this is the patient telling us that after she has a vascular reason, and she is now very much relieved of her pain. Similarly, another patient, she is a patient for brachial plexus injury, and she is having very good pain relief after this T2 T3 sympathectomy. This is one of the most rewarding procedure for this kind of brachial plexus injury. Then coming to the shoulder pain. So if you the management of the shoulder pain has changed drastically over the years. Adhesive capsulitis, frozen shoulder, calcific tendinosis, bursitis, suprascapular nerve neuropathy. These all can be managed with the interventions, and we do both ultrasound guided interventions, do PRP injections, ultrasound guided for the tendinosis. For frozen shoulder, we do both ultrasound guided and fluoro guided procedure. And if your tear is less than 50%, in today's practice, you don't need to have surgery for the tear. But yes, if it is more than 50%, you have to fix the tendon first. But many patients who continue to have pain even after fixation of the suprascapular muscle, they are being treated by us with suprascapular nerve RFA. So you can see we are doing that. This is suprascapular nerve RFA, gives very good results in single sitting, and then patient goes for rehabilitation. So these are the stimulation, and now this is very beautiful picture showing adhesive capsulitis. If you see, we have introduced a needle through spinal needle through AC joint, and we have gone down to the capsule of the shoulder joint, and we have done hydrodissection of the capsule under fluoroscopy, and you can see the dye going around the capsule. And most of the adhesive capsulitis, after that we I'll give 40 milligram of Kenacort, and patient will behave very well. You can see we are doing hydrolysis, hydrolysis of this adhesive capsulitis. You can see beautifully the capsule is being released in the shoulder. And while we are coming back, you can see this is called 3-in-1 block, where we can inject into this is supraspinatus muscle, beautifully seen. Then you go into sub this bursa below the AC joint. You can inject something into the AC joint and come out. So from adhesive capsulitis to suprascapular injection to bursa injection to AC joint arthritis, everything can be treated in a single sitting with a single shot. This is called 3-in-1 block, very rewarding block with suprascapular RFA. You can see the pictures. This muscle you can see is a supraspinatus muscle, and you can see the dye around the capsule which is being released. Very rewarding, very good results for this kind of thing. This is called 3-in-1 shoulder block. Then coming to intercostal nerve block. So intercostal neuralgia, very disabling, particularly post-herpetic neuralgia, post-thoracotomy patients, idiopathic neuralgias, fracture rib, all these kind of thing. And in our institution, if patient is admitted with fracture ribs, and it causes a lot of pain for 2-3 months, and patient is not able to take deep breath, patient is not able to cough. So if there is not a flail segment, we will do intercostal nerve RFA or neurolysis, and this takes away the pain for 2 to 3 months by the time callus forms. Similarly, post-thoracotomy pain, post-herpetic neuralgia, these all can be treated with intercostal nerve block and RFA. This is block and this is RFA, intercostal nerve. So we check before doing RFA what is where pain is going, so that we are confirm of the position of the needle, and this is how we are doing RFA. Then coming to the lower limb, so caudal epidural block for coccydynia, spinal column stenosis, spondylolisthesis, failed back surgery. You can see this is a patient of failed back surgery. We are giving caudal block, and you can see the beautiful spread of the dye in AP and lateral view. This is AP view, inverse Christmas tree appearance, and gives very wonderful results. And then for sciatica, you do transforamen epidural adenolysis. So this is adenolysis being done. We do, adenolysis into the anterior epidural space. You will see the epidural space opening up, and that gives wonderful result. We wash it the anterior epidural space with the 5 to 7 ml of saline with Hyalase, and you will see the beautifully spread of the dye in anterior epidural space. And here you will see the adenolysis being done 3, 4, 5 and S1 level. First we will do neurography, and after neurography we will do adenolysis. I'll show you how adenolysis is being done. So this is S1 nerve root, and now we will do adenolysis. You will see the dye going up, higher up, and the epidural space being released. See the dye spreading. So this is saline with the Hyalase, and we are doing, you can see the dye going into the midline, and we are doing adenolysis. So it washes away inflammatory material, and we use only 2 milligram of dexamethasone at every level, minimal steroid, but this adenolysis works and it gives wonderful results. So we are now stopped using too much steroid into this area. Just do adenolysis, 2 milligram of dexamethasone every level, and come out. And this give very good results. This is low back pain because of lumbar facets. So you can see you have a lot of evidence, class 1 evidence, according to very international many guidelines. And this is the RFA of lumbar facet joint in progress. You can see lateral view, earlier was oblique view. This is AP view, and you can see the lumbar facet RFA going on. This is the generator. Then coming to the failed back surgery. So you can have adjacent level disease. We are doing transforamen and epidural below the level of fixation. We are releasing S1 nerve root, which has entrapped into the scar after the fixation. You can see the S1 nerve root being released. Then you can see SI joint injection, patient after fixation have SI joint problem. Then you can see adjacent level kyphosis above the level of fixation. We are doing RFA of that facet joint. So you can treat many facet, this failed back surgery. The patient continue to have pain after the surgery. You can treat it in your cath lab. Similarly, SI joint pain, buttock pain, sacroiliitis or degenerative arthritis, idiopathic strain, so many things. And I'm sorry to say, but these patients, they end up with some kind of fixation sometimes. If you have disc on the higher level, the pain is still there, and this is a serious diagnostic dilemma. And we have to do thorough examination and history taking. You can see beautiful spread of the dye into the SI joint. This is the radiofrequency ablation. Again, in a post-surgery patient, the SI joint start paining after 1 year, and so we are doing RFA. This is how in a patient. She is feeling any pain. And this is a Iraqi lady who was feeling pain after the fixation, and we are doing RFA of the joint. Similarly, the axial pain, discogenic pain, where patient continue to have pain in the lower back on sitting. He can't sit more than 10 minutes. He can't stand more than half an hour. And he has axial pain, non-radiating. And if you see, you have a lumbar disc, most common L4 and L5. If we see a disc on MRI, which is contained disc, that means not too much of bulging, and on history and examination, patient have discogenic pain. In that case, we do cool radiofrequency ablation of the posterior annulus of that disc, and it gives wonderfully well result. This is bicuplasty or intradiscal RFA. First, we do provocative discography, find out which disc is painful. And I'm very proud to say we have the highest number in the world for doing this procedure with very good results, around 80-85% results. And the another advantage of this procedure is it heals the posterior annulus. So minor tear, they are healed. The lot of growth hormones are released in the back of the disc. And so this we are doing in cath lab. You can see this is a bipolar radiofrequency ablation. So distance between the tip is very important, so it is appropriate distance. And so we have to do this case in cath lab. We can't do it in fluoroscope. And these are the picture. You can see in lateral view, the electrodes are placed on the posterior 1/3 posterior annulus of the disc. We have not gone to the front because the pain comes from the posterior annulus only. The sinovertebral nerve supplies the posterior lateral annulus, so we are ablating the posterior lateral annulus. And uh, this is the video showing that I'm introducing the electrode, and then we will start doing intradiscal RFA or bioplasty. Very rewarding procedure for low back pain, non-radiating discogenic pain, and if on provocative discography you prove that the disc is causing pain, wonderful procedure. Wonderful procedure, gives very good results. Then coming to lumbar sympathectomy, for Berger disease, peripheral vascular disease, you have atherosclerosis, severe atherosclerosis below the knee, and there is no runoff into the distal arteries. You can't do any vascular intervention, neither surgery or stenting. This is the only answer: lumbar sympathectomy in Berger disease or diabetic foot, complex regional pain syndrome because of lumbar plexus injury or involvement into the cancer patients, post amputation pain. Similarly, post amputation pain in upper limb V2T, T2T3 sympathectomy, amputation pain, phantom limb, frostbite, or any sympathetic mediated pain of the lower limb, you do lumbar sympathectomy. This is a very rewarding procedure. You can see AP view and lateral view, 3 electrodes are placed, and we are doing stimulating the patient where patient is feeling pain, and then we do RFA. And if we have to do neurolysis, this is we don't do without DSA to rule out any intravascular spread. That's why all lumbar sympathectomies are done in cath lab. And then coming to the cancer pain, we do lot of cancer pain management. And what is important for international patient, we do a lot of intervention, sympathectomies. These, or you can see three kind of sympathectomy in cancer pain. The left is T2 T3 sympathectomy. Lower one is splanchnic nerve RFA for gallbladder cancer, pancreatic cancer. Similarly, lumbar sympathectomy. This is splanchnic plexus block or radiofrequency ablation for upper GI. You can see just place two electrode and do RFA, and it gives on the average more than 1 year pain relief to a patients with upper GI cancers or chronic pancreatitis, which is not healing, or patients of cancer survivor, pancreatic cancer survivor, who after the surgery and cancer is being treated, they continue to have pain. And the most important part, if you see the lateral view, the left right view, we are not entering into the abdomen, we are on the wall of the spine or along the vertebral body. So if patient has ascites, multiple mats in the abdominal cavity where celiac plexus block can't be done, the splanchnic nerve block or RFA gives wonderful result because it is in the retrocrural space. Then for pelvic cancer, the pain coming from the pelvic viscera, endometriosis. Uh, 2 days back only we have done a patients who have used to have severe rectal pain after passing after defecation, and patient was in severe distress for many years. We have done spiral hypogastric plexus block followed by neurolysis, and patient is fully recovered. So irritable bowel syndrome, interstitial cystitis. I have done a young lady from Iraq who was um, advised ileostomy because she used to have severe pain after defecation, and she stopped going to toilet to passing stool because of pain, and doctor advised ileostomy for that, and we did this, and patient was fully recovered. So these kind of pain, gynecological pain, endometriosis, this wonderfully work well. This you can see we are placing needles into that area, spinal needles 15 centimeter, and this is neurolysis. In this, neurolysis is only done. Then ganglion impar block, particularly for coccydynia patients. Nobody will do the surgery for coccydynia pain. Tailbone pain or coccydynia is very common, and patient keeps on moving in different hospitals for their treatment, and nobody operates because chances of infection are very high after this, and because the anal canal is around. So ganglion impar RFA gives pain relief in 90-95% of the patient. Listen my word carefully. It gives this is the only treatment actually, 90 to 95% of the patient. And then in ladies, perianal pain, vaginal pain, rectal all this kind of pain, neuropathic tenesmus, this ganglion impar block can work. You can see this is a displaced coccyx, and we are doing ganglion impar block, and this is ganglion impar RFA. Very good results, around 90-95% results for tailbone pain. And once it is done in 80% of the patient, it gives relief 18 to 24 months. And if we need, 20% of the patient may require to repeat it, that can be easily done. Then end of life pain. So all patients who are sick, we are doing their end of life care at their home and managing their symptom. It's a part of palliative care medicine. Now coming to the knee pain. So if you see these kind of knees, they require surgery. You can't do justice with these patients because their nerves are being exposed, and they are in severe pain. But there will be set of patients who can't undergo surgery because of various reasons. Suppose somebody has dilated cardiomyopathy, some other reasons, age is too much, muscle mass is very bad, blah blah. There can be so many reasons where they can't undergo knife, or they are not willing to undergo knife. We do a palliative procedure for this, for pain management. We do cool radiofrequency ablation for these patients. This is the cold radiofrequency ablation for pain management for such knees where they are deformed and patient can't have surgery. You can do cold radiofrequency ablation, and it gives on the average of 12 to 18 months of pain relief, around 70% pain relief. And then we give braces to the patient to correct their deformity, and they can have good life, quality of life can be improved with the rehabilitation also. So these are the picture of doing radiofrequency ablation. Now this was the lady who came to us from this is an Indian patient who came to us from Lucknow. She was having 15% LV with defibrillator implanted in situ into the heart, and nobody would operate her. And then she came to us for pain management, and she was on bed for many days, many months. So we did radiofrequency ablation, and she walked after that. And these are the braces that we give them, and at least they can go to toilet, they can cook their food, they can roam about in house, they can do their daily activities. So these kind of the procedure are very rewarding. And for grade up to grade 3 arthritis, you can do bone marrow transplant, you can do mesenchymal cell transplant, you can do this uh, platelet therapies, regenerative therapies. These are done under ultrasound guidance. And now we have mesenchymal stem cell for international patients in India, because they can't come to us for platelet therapy for every month. So it is a one-time mesenchymal stem cell implant which is approved and have a very good result. We can do that for up to grade 3 osteoarthritis in international patients. Heel pain, earlier we used to do fluoroscopy guided, now we have abandoned this. We do ultrasound guided platelet or steroid injection. Most of the time we don't give steroid, we give platelet, because it's a plant part of plantar fasciitis, and you can't give steroid inside the fascia because it can rupture there. So patient needs usually 2 to 3 platelet sitting, which are done at 1 month apart, and very good results in heel pain. Similarly, the advanced procedure like spinal cord stimulator for neuropathic pain, ischemic pain, CRPS, phantom limb, etc. So this is a patient of brachial plexus injury, where we did this test lead first, and patient has very good pain relief. This was again young patients who became drug addicted because of pain, and he was relieved of his pain after placing the pedal lead through surgery. And this was the pedal lead, and patient has very good pain relief. Then coming to another thing, intrathecal pump. I think 7-10 days back only we have implanted an intrathecal pump for spinal cord injury patient, and this patient also come from some African country. I don't remember the name exactly, and the patient was having severe spasticity following the cord injury, and we implanted the intrathecal pump, and we give baclofen into this, and patient is settled with 75 mics of baclofen, and rigidity has gone. Similarly, for pain like failed back surgery syndrome and other thing, you can implant, you can give morphine or combination of morphine. Now see this patient, she has intramedullary tumor at T6. She was operated in Iraq, and after that, she had severe spasticity. See the patient. See the patient. See the pain and spasticity. Patient is not allowing us to touch. This is called spasticity. Now, we did intrathecal pump with morphine and baclofen combined. These are the steps of placing the intrathecal pump, placing the catheter, fixing it, then making the pocket in abdominal wall, placing it there, and see, just after 24 hours, same patient. This is the biggest blessing of Almighty. See the condition of the patient earlier and now. No pain, no spasticity, and patient is comfortable. So these are wonderful things. Then kyphoplasty, our surgical colleague do this now, and for vertebral fracture you can do kyphoplasties. This is a CA prostate patient where we did 3-level kyphoplasty, and patient did wonderfully well. So then testicular or perineal pain. So lot of patients with testicular or perineal pain, females, males, vaginal pain, they can have different kind of neuralgias. From front it can be ilioinguinal genitofemoral nerve, from back it can be ganglion impar or pudendal nerve to the penis, to the vagina, inside the vagina. So all this perineal pain, testicular pain can be treated. This is pudendal nerve block. And after that, this is a Iraqi patient with the penile pain, severe penile pain. And he came to me, doctor, I want this penis to be cut, because he was so frustrated that he can't meet his wife and his severe pain. And we did bilateral pudendal nerve PRF, and patient was wonderfully well. And the funny part about this is the moment we, without stimulating, the moment we switch on the sensory part, patient jumped because he feel pain on the penis. See, patient is having pain on the penis. So we did PRF, and patient, we did lot of these pudendal nerve neuralgias and ilioinguinal neuralgia for perineal pain, genitofemoral neuralgia treatment, and patient does wonderfully well. So these are all for chronic pain. And um, I have my website, janpainclinic.com. So I have beautifully explained the different procedure and the various diseases. Kindly go through it. You will find a lot of information in that. Similarly, I have a YouTube channel with my name, Dr. Ashu Kumar Jain. I have put a lot of procedure into this. So if you have any confusion about any procedure, you can go to the YouTube. You can go to even janpainclinic.com. In procedure, you will find a lot of procedure and patient information, and everything has been explained wonderfully well. Thank you so much. I can take your questions now. And you are mute. You are mute, Varun.
Oh, sorry.
Yes, yes, yes,
Time
yes.
of question answer. Sorry. My apologies.
Yeah,
So we have first question from Dr. Ivan. He's from Uganda. So in
yeah.
RFA, can the treated nerves regenerate? And if so, when can pain reoccur?
No, 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 no. You can't regenerate the nerves. When there is a nerve injury, the patient goes into CRPS2, complex regional pain syndrome 2. And nerve take regeneration takes very, very long time, and results are poor. And most of these patients who came to us with nerve injury, they have complex regional pain syndrome, and this is very disabling syndrome. And we treat these patients because we have a lot of war injury patients uh, with these nerve injuries and all this, you know and we have to treat CRPS. If you believe that you can treat the patient from nerve regeneration, I think it in present day practice it is a myth.
Okay, sir. And sir, here's another question, which is, can repeated nerve blocks cause nerve damage or other long-term complications? And how?
No, it's a very good question. So one thing I want to say, that all these intervention that I have presented, they are they can be repeated, huh? And they don't cause any nerve damage or nerve injury, because the science has improved. Like the pulse generator that I have shown you, it is more than 1 crore rupees. This is most of the, I'm putting it on record. We have the best pain generator in the world with us. So it has a lot of safety feature, huh? And complications are very rare. And in our clinical practice, we have never seen any serious complication with these blocks and RFAs, and they are quite reproducible. You can do the block every 4 to 6 weeks. You can repeat RFA every 3 months, right? So, and they are quite reproducible. That is the beauty of these procedures.
Right. So we have a question from Dr. Chingiz. Dr. Chingiz from Kazakhstan. He's an anesthesiologist, and
Mhm.
his question is, Doctor, can you tell us which local anesthetics, steroids, and adjuvants you usually use for different nerve blocks?
So, nerve block we use ropivacaine, and steroid we primarily use in spine dexamethasone. For joint, you use Kenacort.
Okay. So we have a question from Dr. EPA. Dr. EPA is from DRC. It's in French. So allow me a minute to translate it.
Mm.
Sorry, was that a question for me?
Yeah, ma'am, it's typed in the chat. The question is how to distinguish between pain caused by dyspepsia and pain caused by angina pectoris.
So that is not my domain. That is cardiologist and gastroenterologist domain. We don't treat these kind of visceral pains coming from heart and lung. We are restricting ourselves to musculoskeletal and neuropathic pain, right?
Okay, sir. So, Dr. Ashu, I asked this question to Dr. S.K. Rajan also.
Mm,
Masterclass was last Sunday.
mm,
And quite often, you know, patient present symptoms, they are in pain. Sometimes there's a surgical solution. Sometimes there is like your domain, surgery not
mm.
required,
Yes,
not feasible.
yes,
So can you like little bit talk more about like how you doctors, especially multifunction,
yes.
how to decide
So,
when patients go for surgery or go for medical management?
yes. So it's a wonderful question. Actually, it's a wonderful question. You know, let's talk about spine pain. Huh? In today's practice, if we go to the international guidelines for spine society, uh, any pain which is coming from the spine, if the problem is pain only, patient doesn't need surgery. What are the indication for surgery? If patient has disability, patient has foot drop, patient has motor deficit, patient has sensory deficit. In case if we go by the canal size जो हम MRI पे we are measuring on MRI, if your canal you have more than moderate to severe stenosis, then intervention is probably not the treatment. It can buy you some time, but it can't treat your disease. So for all severe canal stenosis or more than moderate canal stenosis, and patients with the disability, foot drops or severe sensory deficit or untreatable pain, all those patients must undergo surgery. But if the issue is only pain, patient doesn't require surgery, irrespective of the degree of compression. If it is below L2, right? So we at Artemis work as a team. To me, both Dr. Hitesh and Dr. Rajan sent patient and we work as a team. Now, suppose being a pain physician, patient will come to me for pain and I find neurological deficit. I will immediately refer the patient to spine surgeon and I'm not touching it. Understood? So, if patient has disability, severe motor neuron deficit, Kodai syndrome, where they are their bowel bladder is involved, we don't touch this patient. And if pain is only presenting symptom, then we treat the patient. They are very clear cut demarcation into that.
Okay. Sir, now we have a question from Dr. Ngozi. So his question is around sickle cell patient. And sir, this is a very relevant question because bone marrow transplant is a cure, but not every patient can be offered it because of multiple reasons, financial capability, etc. But the painful condition is a reality. So his
Yes.
question is, how can sickle cell patients with chronic pain due to vascular necrosis of the femur benefit?
Yes. So not only vascular necrosis, if there is a femur head is involved, we can do radiofrequency ablation of the hip joint. It is a very rewarding procedure. We block the genicular, ablate the genicular nerve to the hip joint. But if it is involving the bone or some viscera, the best way to treat is with the narcotics. We can't treat this patient with conventional painkiller because giving a higher dose of NSAIDs can hurt their kidneys. Their prime management will be based on like buprenorphine. We treat a lot of these patients morphine or tramadol with paracetamol and with some neuropathic medicine. This is the modality that we do. And if there is a particular target, some nerve involvement or something, that we can do But if that is not that, then it is primarily opioid based with paracetamol. That is the, you can do anything. You can do tramadol, you can do pentadol, you can have buprenorphine patches or sublingual tablet, you can have morphine, you can have fentanyl patch with paracetamol and with some neuropathic do. And you are absolutely right. We see a lot of these patients suffering a lot, and we, with the Almighty's blessing, we treat their pain and treat it very successfully.
So there's a follow-up question from Dr. Ivan, and he wants you to share some more information about deep brain stimulation and
Yes,
bracket for selected
yes,
cases in pain
yes,
management.
yes. So I am not doing deep brain stimulation. Yes, this is a one field that is coming up fast. So deep brain stimulation, Dr. Aditya Gupta is doing at
In
Artemis.
neurosurgery domain, it's
Yeah,
neurosurgery.
it's a neurosurgery domain. It is not a pain physician domain.
Okay. Dr. Ivan, you can ask this question when we do a master class on neurosurgery. So you can ask this question. Now we have a question from Dr. EPA. He's from DRC. So he wants you to talk a little bit about, again, sir, this is the same question that overlaps between spine surgery and your
Mm,
pain management domain. So management
mm.
of pain caused by compression of the L4 and L5 vertebrae.
So, you know, uh, if there is a compression of L4, L5 now, we have to see whether it is a lateral canal stenosis or it is a central canal stenosis. That we have to evaluate. And on clinical examination, we find if there is any sensory motor deficit, right? If patient doesn't have sensory motor deficit, we will treat the pain. And in that, if it is a lateral canal stenosis, we can do transforamen and epidural adenolysis that I was showing, and it gives wonderful results. But if there is a moderate and more than moderate, like severe canal stenosis, with this kind of sensory motor deficit and severe pain, which is not responding to our block, then definitely patient will go for surgery.
Dr. Ashu, I'm not a doctor, but still I have a question. So, in pain management and like in case of sickle cell, that femur necrosis, you talked about opioid as one line of treatment. Now, sir, the thing about opioid or maybe some other nature of drugs is as they can be habit forming or
No,
addictive.
this is again a very good question. So, if you use opioid for chronic low back pain or knee pain or these kind of pain, they are habit forming. But if you use opioid for cancer pain and pain like sickle cell disease, they are never habit forming. This is a very good question. I teach my fellows that if you are using, like in cancer pain, the sickle cell pain is primarily managed on the same line that we are using managing the cancer pain. So there, opioid is one of the topmost drug in WHO ladder, right? And they are very safe for patient safety, for their organ involvement, and they are very potent, right? So they are not habit forming for these set of patient. But if you start using, like America and many countries, European countries, they are suffering low back pain, patient gives morphine, they give so many other opioids, and patient become habit. So for a routine non-cancer chronic pain, yes, it is a habit forming drug, you should never give. We never give to our patients. For cancer and these kind of visceral pain, which like sickle cell disease has, you can safely give.
Okay, so now my question is, like my doubt was not about efficacy or relevance in pain management, but the drug physiology or brain receptors work the same way. So why is it not habit forming in sickle cell and cancer, and why is
So,
when it is habit
so
forming in
yes,
other?
yes. Again, uh, you know, the visceral pain is a different set of pain in cancer and in sickle cell disease. Primarily, it is a visceral pain. Visceral pain, viscera has opioid receptor, but the back pain and all those knee pain, elbow pain, shoulder pain, they are peripheral pain, they're musculoskeletal pain, or maybe neuropathic pain. They don't have opioid receptor, right? The visceral pain is a pain which is taken up by sympathetic system of the body, which doesn't respond to conventional painkiller, NSAIDs, diclofenac and all these. For that, you need neuropathic and opioid drug in combination,
Okay.
right? So that's why.
So,
This
like,
actually the question that we ask from our fellows in their examination vivas. I'm very impressed with your questions.
okay, sir. So, the marijuana-based therapy would also find in the similar class as opioid, like
So
habit-forming.
marijuana is a safe drug as compared to typical opioid. Marijuana is unfortunately not still not approved in India. In foreign countries, we have synthetic marijuana also. And if you have to use these drugs, they are one of the safest option for chronic pains, non-cancer chronic pains. But unfortunately, in our part, they are not still not approved.
And for
Like CBD
musculoskeletal,
oils, marijuana, and all these, they are wonderful therapies, and they can be prescribed.
for both, sir, visceral as well as musculoskeletal.
Yeah. So visceral is anyway, no doubt. For musculoskeletal, yes, this is a safer alternative as compared to opioids. But in our country, government has not approved this. We are still struggling.
But sir, for musculoskeletal, the NSAIDs, they are also like potentially damaging kidney.
So, so
Vis-a-vis. Yeah.
if you have to take for musculoskeletal reason, you are not supposed to take more than 7 to 10 days, maybe 2 weeks time.
Okay. So,
If
so
your pain is
Dr.
not
William is
subsided,
raising
then we need to do other things, like we chip in and we do, like in my clinic, first time patient comes, I don't jump for intervention, huh? I'll give him 7 to 10 days, maybe 2 weeks trial. And if patient after 2 weeks trial says, doctor, I'm not being benefited, my target is 50% pain relief, if not benefited, I'll go to intervention straight away, right? So but the like normal strain, acute disc, most of these acute pain can respond very well to the NSAIDs and muscle relaxant in given for 7 to 10 days, maybe 2 weeks time, not more than that.
Okay. Dr. Miriam is raising a hand. Dr. Miriam, please go ahead.
Thank you. Doctor, is there a list of drugs that fall under your remit that are highly for specialist prescription only? And how do you manage the supply side? Do they, most of them have a long shelf life, or are they stored in a central place? How is that side managed?
So
We
yes,
have a problem with the supply side of certain drugs in our country here in Zambia, and
yes,
I
yes,
think.
I agree. Not only with opioids, I see
Mm,
countries not allowing even gabapentinoids, this pregabalins and gabapentin to carry to their country. I was surprised
mm,
to know this.
mhm,
This Uzbekistani patient, they
mhm,
told me they can't carry pregabalin to their country. They are not allowed.
mhm,
Huh? So, in our country, these opioids, they come under scheduled drug. You need a
uh-huh,
competent doctor prescription. Competent doctor means not a MD medicine or ENT or
mhm,
general surgeon. You need to have a pain specialist or
mhm,
anesthesiologist or a
mhm,
neurologist. They can
mhm,
prescribe, and then there is a for morphine and related, only for morphine and fentanyl. Uh, the hospital has to take lessons for the government to keep a certain quantity, and
uh,
we give a special form. They are special designated form. We write that, stamp our those forms, and they then patient are advised to bring us with their chart of consumption that we submit to the controller, and then we get it that way. But for tramadol, tapentadol, and buprenorphine, you don't need
mhm.
those special form and licensing, but you need prescription, a stamped prescription, valid prescription from a competent doctor.
But sir, in
Thank you so much.
practice in India, some drugs like ibuprofen, if I if I'm not confusing the name, you can buy it over the counter without prescription. A chemist.
Sirji, you can buy Ultraset over the counter. It is a banned drug. Still, people take it for years together. I don't know from where they procure. Amazing.
Okay. So that's something that is for drug inspectors to enforce
Yes,
compliance.
yes, yes.
Because many times, sir, in India, there is a over consumption of pain medication. Like people
No,
just
we call
give,
it as, you know, analgesic abuse. So
yeah.
all chronic Indian patients pay with chronic pain, they come to us with 5 year, 10 year, 20 years of taking diclofenac and Flexone for every day. So it's a horrible situation because over the counter medicine is available. People keep on taking.
So there is another question from Dr. Ivan, and thank you, doctor. Based on your experience, what are the most common misconceptions clinicians, like your community as doctors, have about facet joint injection?
Yeah. So again, this is a very good question. Actually, the first dilemma is for diagnosis only. 90% of the doctors, if they are not trained for handling this kind of spinal pain, they are not able to diagnose festogenic pain. And you know what is the funny part? I see so many patients with festogenic pain being prescribed pregabalin and gabapentin, for years together with zero results. So we call it as axial pain. Axial includes festogenic and discogenic both. And axial pain, you have no use of gabapentinoids, and still 8 out of 10 patients with axial pain are given these drugs with zero results. So first of all, it's a diagnostic dilemma. There are very specific questions on patient history. There is a very specific patient examination to see the festogenic pain. And once you see that, you give a diagnostic block to see whether the pain is coming from the facet or it is coming from some other structure. And once your block is positive, you go for facet joint RFA. So these are the steps.
Okay, thank you, sir. So I think there are no further questions. So if anybody wants to ask a question, please ask. If there are no further questions, okay, there is. It's in French. Let me translate it for you, Dr. Ashu. Oh. So, sir, it is about sickle cell crisis pain management.
Yes, 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 yes.
So
So
he
same thing.
uses how can the pain from a sickle cell crisis be?
Yes, yes. So this patient requires a lot of fluid. Their pH has to be managed. And as I said, in crisis, they need IV opioids. They don't respond to, diclofenac or Voveron. They need IV opioids and their fluid level, their ABGs, and these all to be managed. And we do manage. Primarily, this management is done on intravenous infusion. We use in crisis because patient has to be admitted in hospital. We use PCA for these patients. And once they stabilize and they come out of crisis, then we switch over them to either patches or oral medication. But patient control analgesia primarily with opioids is the pain management primary.
Okay, there is another question from Dr. Ivan. Dr. Ivan, are you are you a fellow in anesthesia? You have a lot of relevant questions around this topic. So, is there evidence that corticosteroids provide better outcomes than local anesthetics alone for facet joint injections?
No, no, no. For diagnostic facet joint injection, you don't have to give steroids for diagnostic. For if you are only treating your patient with facet joint block, you are not doing RFA. So that can give a short-term relief, maybe 6 to 8 weeks, sometimes 12 weeks. Then you have to add some steroid. Usually you can give triamcinolone 4 to 8 milligram at every level with the ropivacaine or bupivacaine, whatever you want to do. But that is not standard of care because the pain will come back. So what we do, we do facet block without any steroid. Then we do RFA. Post RFA, we give 4 milligram of triamcinolone and triamcinolone every level. This is what we do.
Okay, sir, before we conclude, I have a question. If somebody wants to if a doctor wants to make a career in pain management,
Hmm.
what is the typical route they follow? Like, of course,
So,
undergrad in medicine, but
so,
after that, what is general route?
so in India, once you do your MD anesthesiology, you can apply for PDCC courses. You can apply for FNB, DNB in pain medicine. Now, couple of institutions have started DM in pain medicine. You can do that DM, and then our national body, ISSP, has 1 year residential fellowship program. Like I'm a program director of, I'm running that course at my institution. It's a full-time 1 year residential fellowship where you have to give entrance exam, then you pick up your centers. I'm a designated program head of ISSP. The degree is called FIAPM, and we train them for 1 year, and then the body takes exit exam also. So we only train the doctor. Entry and exit comes through national body, and once you clear that exam, you are given degree of FIAPM. Similarly for PDCC, DNB, I'm going to start DNB at my center very soon, and then DM is now have a couple of AIMS and institution have started DM in pain medicine. This is how you can do.
So, do you accept fellows also from foreign countries in your institution?
So, from foreign institution, I don't think somebody will be willing to come for 1 year. If somebody is willing, we can talk to HR. But we have a fellowship for 1 month and 3 month. Sometimes fellows they come for a month or 3 month. But if you seriously want training, you have to have it for 1 year.
Okay. Thank you, Dr. Ashu, and thanks a lot for taking time out on a Sunday, and you had back-to-back speaking obligations.
Yes, I'm so
This-
sorry
No, no, it's okay, sir. We
for
totally
that.
understand. And our audience, the doctor community, sir, they all understand. You all
Uh,
understand each other's constraints. So,
Actually, that talk was designated for 30 minutes. It went for 70 minutes. So I
sir,
was talking to elderly group of almost 150 people for educating them after chronic pain. Then suddenly I realized I have another this thing. So I that got late. I'm so sorry for that. But I
I
hope
want
this will be informative.
I want to thank the doctors, who were here
Yes,
and
yes, yes.
patiently waited, and
I
they
sincerely
understood.
apology from my heart, and
No, sir, no
this is
apology required, but I just want to thank all of you
yes.
also, and the audience members, that I had asked them, I had given them the option that either we can wait or we can reschedule. They opted that we don't mind waiting. Let's go ahead with the masterclass. Thank you, everybody. And like earlier, while we were waiting, when Aditya spoke about Jivo's like organizing so many masterclass over the years, that requires a lot of consistent effort. And I again want to give credit to two other players. One is the audience, the African doctors, because your participation in this ecosystem, this makes everything meaningful. And the second, thanks to institutions like Artemis and other hospitals that co-organize, and doctors and specialists like Dr. Ashu, that if you don't participate, then there will not be any masterclass. So if the African doctor community or doctor community, because we have one from Kazakhstan also, if doctor community from overseas, and if the institutional setups here in India, like Artemis and specialist, if we don't participate, if they don't participate, then masterclass won't happen. And my dream is that this start of this cross-border collaboration, knowledge exchange, or referral, I hope this expands and this becomes institutionalized, so that the patients can get a guided care initiated by their local doctor, specialist input by doctor in India, and in a serious journey like medical travel, nobody has to depend on an intermediary or an agent. The doctors, they can directly talk to the specialist and decide for what's best for the patient. Thank you all. Thanks a lot for your commitment. Thank you.
Thank you. Thank you so much. Thank you.